Now we should have Tony Kraina that should tell us something about training in the endovascular treatment of ischemic stroke. Hi, man.
Good afternoon to.
Do you hear us?
Yeah, I can hear you.
Okay, Tony.
And just try to share. Have you seen my? Do you see my screen?
No, we see
No.
you, but not the screen.
Okay, so I try again. Now?
Yes, we can.
Okay. All right. So, good afternoon to Belgrade, and it's a pleasure to join your stroke forum. And I will speak about the education and training and in interventional neuroradiology treating ischemic stroke. The primary goal of it is a broad knowledge base, then procedure skills and experience, and then to get professional judgment and self-criticism. And everybody knows that ischemic stroke therapy doubled number of neurointerventional vascular procedures, and therefore some regulatory processes have been started to keep quality assurance, either for patient benefit and legal backup for physicians as well. I mean, why we train the doctors to do so? That sometimes they have to face complication as this one. They have to diagnose it as early as possible and possibly to treat it. Majority of cases are quite simple, just M1 occlusion with a straight anatomy and nothing difficult. However, this has to be diagnosed and somehow treated. So they have to do some embolizations, then placement, and so on. The first training guidelines based on the International Multi-Society Consensus document was published previously in at least 2 journals under supervision of many societies on the whole world. Last standard of European training requirements had been published in 2019, and based on consensus of UMS, European Society of Neuroradiology, and European Society of Minimally Invasive Neurological Therapy. And I will show you just some basic things I consider to be important to know. First, trainee selection criteria should be defined at national level according to national medical regulations. Then training could be limited to a specific area of interventional neuroradiology. And then how long minimum, what's the minimum of the training? That means that the 2 months of neuroradiology, 2 years of interventional neuroradiology, and 1 year or 2 months in neuroscience. So that's important, and we will stick to this program. That should be or listed what everything should the candidate have in the training. And also there is a stratification of technical skills into 5 degrees. First, that he's observed the case, then did it with assistance, can complete but may need help, is competent, and finally can be trusted to carry out the whole procedure independently without assistance or need for advice. So five levels. I like to just highlight these perspectives. I mean, the physician must have technical knowledge of practice in neuroradiology and neurology. Minimum training 2 years and could be shortened according to previous experience by the director of the program. And in addition to mechanical thrombectomy, as I demonstrated on that case, physician must be able to implant intracranial stent, and do embolization. And organization of stroke therapy in centers, their interventional neuroradiologist must be, so it should be done under supervision of the interventional neuroradiologist in these centers. We don't have enough of these doctors, and the question, which I will borderlinely, that who can do these procedures, catheterization procedure, who can place the catheter and treat the ischemic stroke. So only stroke only, that's the shortcut. A very specialized 2 years of neurointervention, 6 months neuroscience, and 6 months of neuroradiology. And as I said, this can be shortened based on previous training skills. Why is certification in stroke treatment necessary? Make sure that treatments are only performed by people doing it in the right training for the right reasons. And nobody wants his or her family members being treated by someone only does the procedure because of his ego and the monetary gain. There are several European societies which are included in this training programs. And this is the position statement of the Cardiovascular Interventional Society of Europe, that interventional radiologists could be led by their local neurointerventional colleagues. What can be offered for training for young doctors, and that might be for the future for young doctors? First, it is the ESMIN Fellowship Program. And at the end of this program, the trainee should have performed at least 25 stroke procedures as a first operator and able to manage clinically and endovascularly the vast majority of stroke cases referred to their own center. And the components, that means this is 1 year training and is financially, at least by part, financially supported by ESMINT. So here are the famous professors of European International Neuroradiology from their hospitals. You can apply the 1 year fellowship under certain condition through the website of ESMINT. There is also observership program, which offer informal learning experience and a visiting observer in a university hospital environment and the same places as the 1 year fellowship. The observership is scheduled from 3 to 6 months and is also financially supported if you get that grant by ESMINT. Besides that, there is a so-called AMINT E-Fellowship, which is more spread, as you could see, that these doctors and the mentors included in these, and maybe some of you present in your meeting are there sitting. So this is quite interesting, since it's something which facilitates availability to see interesting cases in these highly busy centers in stroke, not only the ischemia, but also the aneurysms and AVM. So that's also possible for the young members of ESMINT. There are also the courses available through the ESMINT. First is ECMINT, which includes 4 weeks of theoretical training in Oxford. Among them, 1 week is dedicated to the stroke therapy and was started in 2014. And ECMINT, which is European Stroke Course, which was started in 2018, and it's dedicated only to the ischemic stroke therapy. Both these courses, after finishing them, the candidate can apply for examination, and if he succeeds or she succeeds the European diploma in neurointervention, the general, and ischemic stroke is European diploma in ischemic stroke interventions. So that's it. Since I am involved in the EXMIN course, which had the next 6 continuation, and the first part is online, the second part is on face-to-face. I should also announce that there is the course of ischemic stroke, which is organized in Maastricht, Netherlands, this year, and this I am involved as a member of program planning committee, which is now just we are working on it. So back to the EXMIN, and they are, since the first part is online, and we switched to continue with this courses during the COVID era. So the first week is online, and these are the students of the last course. Second part, this is how we get together to discuss certain topics. And second part is more practical and is on site in Prague, and still the half of the price is supported by the EXMIN. There are daily tests and final tests in each course, and it's endorsed by EXMIN, ESO, and CIRSA. And finally, I should mention that some data, only 35% of the world population has access to acute ischemic stroke treatment. And that's one of the reasons why we do this. Second, that's interesting, that the mortality after mechanical thrombectomy in anterior circulation stroke may be higher in nighttime and on weekends. So this is the interesting study done in Munich, in Germany. And that definitely the mortality during the day was 7%. Daytime on call duties was more than double. And nighttime was 20%. And this was not explained by the fluoroscopy time, by the long haul the procedure, and so on. So I mean, that's something which should we pay attention to, and maybe look in our own practice in our center. It could be just a general effect that something like a weekend effect is described also in other specialties, including the surgery. So therefore, there are also the quality measurements, the 3 months ranking score, and time to reperfusion, symptomatic intracerebral hemorrhage in our practice, final infarct volume, and transportation time. So all these data are collected and should be analyzed afterwards, and the local team has to analyzing these data, decide what should be improved locally, which would be the different from center to center. And still, that has been proved in my country, that a significant variability among not only among countries and comprehensive stroke centers, as was already published 2018. But I mean, still we have a lot to improve in our general practice and our everyday practice. So therefore, I just introduced you basic courses, fellowships, and also there's also from CIRSA e-learning materials, e-learning courses with tests which you can apply for, and you might find them on the websites. So that's it, and thank you for your attention. And if you have any questions, I would be happy to answer them.
Thank you, Tony. First of all, congratulations on the great effort for teaching the young ENRs, and I'm sure that we'll get the fruits of that your effort very soon. More and more, we need the young physicians that will be on board and help us in increasing number of mechanical thrombectomies, also in other interventions in ENR. Can you tell me something about regulations in your country? How did you do the regulation of the training, and is it official for the ENRs, and what you showed us in the first part of your lecture?
Actually, we don't have the dedicated specialization in interventional neuroradiology. And so, I mean, majority doctors who these procedures in comprehensive centers are interventional radiologists. That the important thing that we have at least 3 to 5 of them in each center to cover 24-hour service. But they have to do everything, not only the ischemic stroke or subarachnoid hemorrhage procedure, but also any other procedures included from the interventional radiology. So that's something which somehow works last 7 years, and results are, if you look on the difference among centers, they are in the mortality and independence rate, there are some significant difference, and which has to be solved somehow, basically on the centers having the independence rate, which is over 30% in comparison to the maximum independence rate, which is about 53%. So I mean, we work on the standardization. However, it's a process.
Hi, Tony, this is Vlado. Related to that, do you think that this should be uniform to whole Europe as a whole, and that we have a standardized teaching, learning, and skill training for each country, or to Europe per se, like to see Europe as a continent and to have standardized therapy prescribed by joint, SNR, ESMINT, all together, CIRSE. And then what we have now is all this diversity through each country, through each hospital. What do you think?
Definitely, we need to unify the requirements for training. And, we are now, at least me, who introduced continually these procedures. So we have to look on this generation of young doctors and at least try to make an agreement among societies to at least little bit standardize and unify these training courses. But I mean, for the future and for now, there is a wide variability. So there are many schools of stroke organized by separate societies, and different courses with, different variable deep of the training. But I speak about the theoretical training, and the practical training. That's completely different story. And I just mentioned that it's possible to apply for these fellowships or observership.
Thank you.
Thank you, Tony, for your effort to be here with us. Wonderful lecture, and hope to see you next time in live.
Yeah, thank you. Have a nice evening and afternoon in Belgrade, and I'm sorry that not being with you. And but thank you once again. And I just observed this session; it was very interesting.
Thank you very much.
Thank you, Ivan.